Hey everyone, today we're going to pick up again from the last session, and what we're going to do in this one is we're going to pick up immunopathology, right? Um, so we're in this session we're just going to do complement problems again, hypersensitivity, looking at all the different disorders and stuff like that, and looking at transfusion and transplant reactions. Okay, so we have things to cover, so let's get into it. All right, so we discussed complement disorders last time too, but I do want to emphasize on a little bit, on those types of disorders and making sure that we cover all the points that you're going to see in the stem, right? So first is C1 esterase inhibitor deficiency, right? We've seen this, we know what happens, but just to distinguish between the pathology, for example, you have the angioedema episodes, which are usually 1 to 3 days. Most of the symptoms are going to be like flu-like, right? Flu-like, for example, fever, myalgia, just fatigue in general, and it's usually going to be triggered by stress, right? But then as soon as you cross that threshold, you start to get edema. Now, this type of edema is not going anywhere. It's non-dependent, right? There's no itching because the fluid is not actually, escaping, because of the difference in pressure, right? This is because there's like actual cytotoxic edema, right? Now, because of that, you see, it goes in different places. For example, it can go in the GI system, right? Cause GI bowel edema. It can go in the larynx, cause laryngeal edema, right? Now, if laryngeal edema or GI bowel edema are once they're there, the fluid is not going anywhere, right? Which may require surgery, right? Or even with laryngeal edema, if you have large amounts of laryngeal edema, it's going to require intubation, right? So angioedema and edematous episodes, very, very, severe forms of severe things seen with C1 esterase inhibitor, right? How are you going to diagnose it? You're going to have that lab values. You're going to see that the diagnosis is dependent on the complement levels being low, right? Now, the treatment is usually you have to give the inhibitor, right? You have to give this inhibitor to the patient. Only then can it work. Or what you can do is you can give bradykinin antagonist, right? Reverse whatever the cause of the angioedema is, right? If both of them don't work, make sure you give them fresh frozen plasma. Okay, FFP is the way to go because now they're gonna need the plasma which has C1 esterase in it, right? So that is gonna be C1 esterase inhibitor deficiency. Next, coming to C2 deficiency. You see in C2 deficiency, if you remember, usually there's no classical cascade, right? And if you don't have the classical complement cascade, especially in children, because this is a genetic disease, usually it's autosomal recessive, you see that this is one of the most common deficiencies. And this presents like SLE. So what you end up seeing in the child is fever, rash, maybe some joint pain, right? And eventually this turns into like glomerulonephritis or maybe even a high infection risk. The reason why this is sort of happening is, you see, if you have like, lack of complement proteins, the body it starts to have this autoimmune type of reaction, okay? And eventually you're gonna start to see like autoimmunity starting in these patients, okay? So apart from just like the lack of immune action which causes infections, you start to also see SLE like flares, SLE like episodes, right? And for that you're gonna have to give them corticosteroids, right? So that's how you sort of manage C2 deficiency, okay? Next is C3 deficiency. C3 is one of the rarest ones. Is usually seen in infants. The thing is, the C3 was responsible for a lot of opsonization, right? If you don't have opsonization, you're not going to have proper phagocytosis, antigen presentation, etc. Right? C3 was also the main one which was using and making that C3 convertase, right? If that is not happening, you're going to have no activity of no complements, no clearing of immune complexes, so you have infections with encapsulated bacteria. And then you get the hypersensitivity type 3 type of symptoms where you see the immune complexes are becoming more and more prevalent, right? So, a common theme with these complement things, which you'll see is you get the infection, but you see some sort of autoimmunity sort of developing, right? Lastly is because the C3 and the phagocytosis wasn't working, you will start to see abscess formation, right? The immune system is not fighting it, just containing it. That's the principle, right? Because fighting it would require these complements, but you can only do so much and just contain them for now, right? Now, if the person survives from the infection, like the infant survives the infection, the actual later on threat becomes membranoproliferative glomerulonephritis, right? Which is a nephritic type of presentation. Okay, so we have to look out for this hypersensitivity developing later on in life, right? Diagnosis is still complement testing, and then you look at the treatment. You see, you have to fight the infection. You have to give them vaccination against all these different types of encapsulated bacteria, right? Most common being strep pneumo and meningococcal, right? So these are going to be the two main ones. Lastly comes C5 through C9 deficiency. You see, C5 to C9 means no MAC complex. Next, and because you have no MAC complex, one of the most common ones are Neisseria. So gono plus meningitis, right? Again, antibiotic and vaccination is the way to go, right? Now PNH, we've seen this already too. We know exactly what's happening in that, right? We know that it's intravascular hemolysis. The reason why you see that it's nocturnal hemoglobinuria is that while sleeping you have slightly high amounts of CO2, which leads to acidic pH, which basically increases the amount of complement activity, right? So when you wake up, you get morning hemoglobinuria. So now you know the cascade, right? Because of damage to endothelial cells, you see the arterial and venous thrombosis. Damage to bone marrow, we see you basically are cascading the bone marrow towards dysfunction, right? So aplastic anemia, myelodysplasia, myelofibrosis, eventually ALL, leukemic transformation of the bone marrow, all possible because you're damaging it. Okay? The signs and symptoms are usually, the pain is everywhere because you're damaging blood vessels everywhere, right? Then you see splenomegaly, right? Usually, splenomegaly usually happens because um, either you're destroying a lot of RBCs and that it's taking place in the spleen, or you have something like this where it's intravascular where the proteins and the all the recycling of those components are going to happen in the spleen, right? And then you see thrombosis slash hemolysis. Both of them are going to be seen. Diagnosis, you see normocytic, normochromic anemia, right? Because overall, you're going to eventually start to damage all the blood cell lines, right? Pancytopenia and then high LDH, which just makes sense because you have intravascular problems. Now, what I want you to focus on, and the reason why I did this is because of these tests, okay? So, there is a test called the sugar water test. Basically, what you're doing is you're taking the patient's serum and adding some sucrose into it and seeing if the cells lyse, right? If they do, then you have PNH basically, right? Because somehow the complement proteins were supposed to defend you from some sucrose or something like that, and whenever you give sucrose, I guess the complement activity increases. The same principle applies to acid hemolysis test, right? So when you have acid hemolysis, or when you add acid, the complements activate and sort of leads to lysis, right? So that's the confirmatory. Otherwise, we've seen this before, flow cytometry, right? If you haven't seen a picture, I'm just gonna add it here, flow cytometry test. So you see, they give you a plot of the graphs and stuff, right? So let's just analyze this quickly. So you see, there's two graphs that are going on. See, with all of these different quadrants, somewhere they'll say that this is CD55 positive and this is CD55 negative, right? This is CD4, CD3 positive and CD3 negative, right? You have to pick out which of the cells are basically containing the CD marker versus which one of them are not, right? And if the patient's sample lies in that quadrant, you're going to know that this person does not have any CD59 or 55 in their system. Okay, so that's how they sort of present it in the NBME. Okay, all right, so that's done. Glucocorticoids or corticosteroids for patients to suppress their immune system. And then the next thing is the C5 monoclonal antibody, eculizumab, right? We saw this last time too. The overall cure is just bone marrow transplantation because nothing else would get the job done basically. Okay. All right. Now let's go into hypersensitivity. Right. The basic definition is that it's intolerance. Okay. Hypersensitivity means intolerance. As hypersensitivity progresses, it becomes autoimmunity. Right. Now, given the breakdown of the easiest way to learn hypersensitivity. So type 1, just remember allergy. Okay. Type 1 is a basic allergic phenomenon. Type 2 is when you have antibodies circulating within the body and they cause destruction, right? They cause malfunction, they cause destruction, right? Type 3 is when you have immune complexes going in and around your circulation, right? And they activate a lot of cells, they activate a lot of complements, etc. Okay. Type 4 is when you have cell mediated, which means everything that you saw in the first lecture, like APC, T cell activation, natural killer cells, and then we saw CD4 and CD8 activation. All of that is a part of hypersensitivity type 4. Okay. Now, next group of points is that most diseases are usually one type of hypersensitivity, right? But then there's a couple of disorders. You see, I've written the name here, right? These are mixed type of hypersensitivity. For example, hypersensitivity pneumonitis. This is in the first aid. I'll give you the page for you guys to review. So it's a restrictive disease, and you're gonna come here. Page is 694, right? So all of this are spread throughout the book, right? One of them being right here. So we'll take a look at hypersensitivity pneumonitis in general. But remember that this is a type 3, type 4, right? Transplantation rejection, depending on what timeline you're at. It could be type 2, it could be 3, it could be 4, right? All of that is a part of it. Latex allergy. It could go with the IgE mediated type 1, right? Or it could go in like contact dermatitis type 4, right? Sjogren syndrome. Sjogren syndrome is usually like an antibody that is directed towards an antigen. So it's usually like a type 2, but it can behave like as an immune complex phenomenon, right? So Sjogren's. Same with all of these. So autoimmune hepatitis, adrenalitis, systemic autoimmune disease. You see, all of these are mixed type of hypersensitivity. Now, do they ask you like, well, which type is which? Usually they don't. But the thing is, the mechanism of the each and every sort of pathology needs to be understood, right? So whenever you come across these diseases again, make sure you go through how exactly they work. Okay. Now, I've written some like general diagnosis points. For example, in type 1, in order to get there, because it's mostly related to the lung and like, IgE mediated stuff, you may need to do like pulmonary function testing, right? You may need to do spirometry, okay? Get their IgE levels, get some like skin tests or allergen skin tests and stuff like that to make sure, what is actually going on with type 1 people. In most of the other questions with type 2 and 4, you're usually going to see antibodies, either get those antibodies from the serum or plasma, or get a biopsy of the tissue, right, to get exactly what type of cells you're going to see in there. Okay, so that is the basic presentation. All right, so usually you can the best way to study it is through first aid, but some of the points that are in the first aid are less explained than usual, right? So I'm just gonna elaborate. Whenever you guys study, make sure you cover both the notes that I'm presenting on the screen versus whatever is in the first aid itself, right? So let's begin with hypersensitivity type 1, right? You have to know the mechanism or at least the outlines of the mechanism. Otherwise, the nuanced questions about immunology are going to be lost, right? And trust me, there is enough like details in immunology that they love to ask, okay? First thing is sensitization, right? With HSN1, the first phase is sensitization. What happens here, you see allergen binding to APCs, APCs presenting it to B cells, B cells can start to form, or APC is activating Th2 cells, and they both start to basically form, these transform into IgE mediated problems, right? So basically, these allergens bind to the Fc region and they activate mast cells, right? So once these mast cells have sort of sensitized, right, the next is re-exposure phase, right? In re-exposure phase, you have two phases. You have either early phase or the late phase. In early phase, within minutes, you're going to start to see massive IgE flooding from the Th2 cells, right? And mast cells will undergo degranulation because of that. Okay, so that is the early phase. Then comes the late phase, usually 8 to 12 hours later, because what is happening here is now you're allowing the immune system to generate more molecules. For example, IL-4, 5, 10, all of that. Even leukotrienes are going to be involved now, right, from the prostaglandin pathway. All of that will cause prolonged inflammation, breathing problems, right, bronchoconstriction and all of that, bronchospasm and all of that, right? So, understand the difference between these different phases and the cells that are involved here, okay? So let's just quickly take a look at it. For example, you see here, right, mast cells, degranulation, usually, the stuff that they're releasing, that's the important part. So I've written histamine here, but then one of the main ones is this tryptase, and I've made a note of it here too, okay? So when we go down, you're going to see it. But yeah, anything else? No. So, and just remember the testing. Usually a skin test or blood test like ELISA, but usually you're not recommending ELISA for everyday things. Usually the person knows because they've had a reaction to it, or you're gonna perform a skin test or something to get it quickly. Okay. All right. So, what is the treatment? Usually you're gonna give antihistamines. You can give corticosteroids, and if it's severely acute, you're gonna give them epinephrine, right? Later on, whenever they say this is all done, you might need to recommend a desensitization slash like exposure therapy to get them used to these antigens, right? They can choose to do that or not do that. That's up to the patient, but that is one of the things you can recommend. Okay. And I've just written common like presentations of hypersensitivity type 1. So you see all of this. Even eosinophilic esophagitis, right? Very, very common sort of thing in GI, and I can show you the page and stuff. But whenever you see eosinophilia, just remember Th2 activation. Okay. Now, just a part of the whole cascade of things. Remember, you have to differentiate between diseases, right? One of them being acute rhinitis versus anaphylaxis. Okay. Acute rhinitis is just nose, upper airway symptoms, right, caused by these types of allergens. Hair, hay, pollen, dust, animal hair, mold, etc. Right? And it's usually just upper respiratory symptoms, which basically, rhinorrhea, eyes watering, the nose closing up, and stuff like that. Right? But anaphylaxis is life-threatening, right? And the reason why it's life-threatening is because of the compounds that you see here. Right? First of them being histamine, next one being tryptase. That's the thing we broke down. Right? The thing is with tryptase is that tryptase can activate complement. Okay, so we have to remember the things that it does. So it can activate complement, it can activate the coagulation system, it can activate the bradykinin system, right, leading to a massive amounts of angioedema, hypotension, or even DIC. Now that is the life-threatening part, right? And the second life-threatening part I would say is like leukotrienes and prostaglandins, basically leading to bronchoconstrictions. You're going to lose your airway and all of that. Okay. Now, as we love to correlate, what we're going to do is just look at how different histamine receptors work. Because histamine receptors are going to be seen here, they're going to be seen in GI, they're going to be seen everywhere else, right? So one of them, start with the H1 receptor, right? H1 is usually seen with smooth muscles and endothelium. I would say that's the main thing you're going for, right? Usually this is a GQ pathway. Everything else is GS or GI, but this is the GQ pathway. So it makes sense. Usually they're going to have calcium and stuff, may lead to like vasoconstriction and all of that. And when you give someone like something like citrazine, which is an antihistamine, basically vasodilates, right? So that's what it's good for. H2 blockers is the H2 pump blockers, usually in the gastric mucosa, right? This is the thing that you're using for um, to help them, prevent hyperacidity, right? But they're also located in other neurons, like tissues like cardiac, mast cells, or even brains, okay? Now, they're working with the CAMP proteins, right? CAMP's intracellular signaling, so important, okay? The rest of them, as you see here, H3 and H4, these are mostly neuron-based. H3 is mostly neuron-based, and then H4 is mostly eosinophils and immune-based, right? So usually what you want to inhibit with the, antihistamines is the best one is this, right? H4. But, antihistamines are not usually specific. They have two different generations, which the first generation is just, you know, it blocks everything, but there are selective ones which just block H1 or H1 and H4 or something, right? They don't block this, right? So there are different generations. So keep this in handy. I would say this, like one, two, three columns, and some of the drugs here seem familiar, but others aren't too much. Okay, so keep this handy. All right. Now, usually for anaphylaxis, you're gonna have to do epinephrine every 30 minutes until they're okay, right? You have to give them antihistamines. You may not. You might have to give them corticosteroids. The thing is, you have to manage the hypotension. That's the main thing, right? Because that's the thing that's going to kill them. So you're going to start vasopressors, IV fluids, O2 supplementation, the usual stuff you do to manage a hypertensive patient. Okay. Now, next comes food allergy, right? Food allergy is still a part of hypersensitivity. The thing is, this is subdivided into three categories, right? IgE, non-IgE, and mixed type of thing, where you have IgE/non-IgE presentation, right? This is the thing that people get wrong. This is the thing that people don't understand, right? They think that IgE is just hypersensitivity type 1 and non-IgE is hypersensitivity type 4. Okay, that's what we're trying to rectify here. Okay, so understand that all of this is still under hypersensitivity type 1. Some have pure forms of IgE, some don't. Okay, so for example, with IgE, usually the effect is rapid, right? In mast cells and basophils, they go and activate like really really quickly, right? For example, like someone says shellfish allergy or peanut allergy, right? It's still a food allergy, but it's categorized in IgE mediated because it's so quick and it happens very very fast, right? Whereas you see something like non-IgE mediated, it's usually chronic, and this is mitigated by T cells. So compare these two cells, right? Because they're granulocytes, they have like quick degranulation, but T cells don't do that, right? They're not granulocytes. These will maintain the time, and they will take their time and destroy tissues, in the long term, right? The celiac disease, post protein enterocolitis, or protein enteropathy, that's what you're looking for here. Okay. Then comes the mixed part, which is just the overall like typical hay fever, right? Or even the atopic dermatitis, like the triad that you see, or eosinophilic esophagitis due to, for example, like some drugs or something, right? Or eosinophilic gastroenteritis, like again, some drugs or some pathogen or something. Something has reacted with the mucosa, leading to eosinophilia, right? Usually the treatment is same as most of this, right? You want to maintain the vasopressors and all of that. Give them epinephrine, give them antihistamines, corticosteroids, and then look for dietary changes, right? Lifestyle modifications. All right, so I hope everyone understands the type 1 hypersensitivity. All right, now comes type 2 hypersensitivity. So type 2 is versatile in a way because antibodies are versatile, right? The four ways the type 2 hypersensitivity works is first being complement activation. Okay, the antibodies, they bind to the antigen, right? Usually, if it's an hypersensitivity, usually it's your tissue, right? Some tissue they've bound to, right? The circulating antibodies. And once they have bound to it, they trigger the complement cascade, right? Once they trigger the cascade, they're going to lead to degranulation of neutrophils, basophils, mast cells, massive amounts of cell death, massive amounts of mast cells and MAC activation, all of that. Okay, so that is one way that antibodies trigger your immune system, right, into damaging certain tissue, right? Next comes opsonization and phagocytosis. You see, C3b was the main thing that was sort of, marking something to be phagocytosed, right? If C3b is not working, right, then you're not going to have that thing anymore, right? Or if it's irregularly working, for example, let's say the C3b points out that go ahead and eat this part of the liver or eat this part of the spleen, right? Or eat this gland or cell or something, right? If they go and land there or even go in the nephrons and eat that, right? If they mark that for opsonization and they just stay there, then the immune cells will go there and eventually try to eat those and destroy those, right? So usually, you see, this is the one of the other ways. One of the most like, and we'll discuss all the different hypersensitivity presentations. But imagine your red blood cells, right? Red blood cells, if they're marked with IgG or if they're marked with C3b, they circulate, right? They circulate and eventually they land in the spleen and the liver, right? And the spleen and the liver macrophages, they eat those RBCs. So that's the mechanism of like autoimmune hemolytic anemia, right? So that's another way that hypersensitivity type 2 is sort of functioning, right? Next is ADCC, right? Antibody dependent cell cytotoxicity, right? We've seen this, right? We're just using an antibody for an excuse to degranulate the natural killer cells, right? So what we're going to do is they're going to bind to the FC portion of the IgG, and the antibody is bound to the antigen, right? And as soon as that linking happens, the natural killer cells degranulate, just release perforins, granzymes, caspases, all of that. Just destroy the cell in all different types of ways. Okay. Next comes antibody-mediated cellular dysfunction. This is one of the unique ways. The thing is, the antibody can go and attach to a receptor, right? It can activate a receptor, it can inactivate a receptor. That's the important part, right? So some of these, for example, like Hashimoto's, right? Or even Graves' disease, they're still hypersensitivity type 2 or type 3, right? But in Graves' disease, you're activating the receptor so much that it leads to hyperthyroidism, right? So that is what you're looking for here. Now, I've given you a couple of like testing. I mean, if we um, need to discuss it, we can. Usually, Coombs testing is the main thing that we're going for, right? The Coombs testing is that you have two ways of actually approaching the antibodies, right? So I'm just going to go to heme for a second and just show you the stuff again. Yeah. So page is 416. Just make sure you understand everything that's going on here. Okay. Now, Coombs test is basically trying to detect if you have antibodies, right? Now, the thing with antibodies is they can be bound or they can be free floating, right? So when I have the Coombs reagent, which is just a bunch of antibodies which bind to certain other antibodies, then what I'm going to do is I'm going to give this to a patient. Okay, the Coombs reagent is just a bunch of antibodies, right? And when you want to test for like something like in direct Coombs, what happens is you're testing for something that is bound. So the RBCs are actually going to be bound to the antibodies. Okay, but when you look at indirect testing, you see there is no bound antibodies, right? They're free floating. They're in the serum. They're in the plasma. They're free floating, right? So the difference between direct and indirect is this is bound antigens and antibodies, while this is free floating antibodies. Okay. Now what you're gonna do is you're gonna give the Coombs reagent to the patient, right? If they have a reaction, what's gonna happen is, see, as you see, this is going to cross-link with the Coombs reagent and make this into a coagulation, right? So you're gonna see that there is coagulation happening because of the Coombs reagent. That means it's direct positive, right? Because there's already antibodies that are bound to the RBC. Okay. The most, the one that I said, autoimmune hemolytic anemia, IgG or C3b has bound to these RBCs, and then you add the Coombs reagent, and everything clumps, right? So now you have positive direct Coombs, right? If they say that the direct Coombs was negative, all right, now they want to do indirect Coombs, right? Well, if they want to do indirect Coombs is, then these, how will I detect these? You see, they only bind to the Coombs reagent if they were bound to something, right? If they had combined with the antigen, then they would be ready for Coombs reagent, right? But they're not. So what I'm going to do is I'm going to add sheep's blood, okay? So whenever I take the patient's serum, I take the sheep's blood and I take the RBCs from that sheep's blood and I give it to these guys. These guys will bind to that sheep's blood, right? And then these Coombs reagent can bind to these guys. Okay. So that's the indirect part. I have to give them like this uh, sacrifice, which is the sheep's blood, and then you can see that the Coombs reagent will bind to it, right? Now, once that is positive, you see indirect Coombs is positive. This means that patient's serum is having RBCs, free floating, as antibodies against RBCs, free floating in the plasma. Okay, so that's the essence of direct versus indirect Coombs test. Okay, so you look at direct antibodies bound to Fc region or indirect antibodies in the serum. Okay, hope you understand that. Next comes a couple of other testing that they might or they can bring up. One of them is RBC antigen testing. For example, they just take a bunch of antigens and they throw, they take the patient's blood and they keep adding to the wells, right? Trying to determine which one of these antigens is actually having the antibodies and actually destroying cells, right? So that's one of the ways. Other way is immunohistochemistry, right? Immunohistochemistry or stains or immunohistochemical slides. What they do is they have antibodies, right, which basically bind to tissues. Okay. Now, once they bind to tissues, they change into a different color, right? So, for example, you see, this slide is negative. This is just immunohistochemical slide, right? This slide is negative. But then you see, you gave them something like anti-nucleo something antibody, and then the reagent lights it up and turns it brown. Okay. When you look at a cytoplasmic anti-cytoplasmic antibody, right? We've seen when you look at like P anchor and C anchor, right? C anchor is supposed to be cytoplasmic, whereas P anchor is supposed to be nucleophilic, right? So if they say nuclear regions are lighting up in immunohistochemistry, right, then you know that where is the antibody is directed towards the nucleus. Here, the cytoplasm, okay? Here it's membranous, so the membrane is being destroyed, right? So some protein in the membrane is being destroyed. So you see, this is very like pinpoint accuracy of exactly where these antibody targets are, okay? Now, otherwise, the last one you can sort of use, and mostly it's reserved for thyroid, which is just diffuse radioactive iodine uptake, right? Basically, what you'll do is the iodine will be marked with some sort of antibody, right? The antibody will go and attach to the tissue or the antigen, right? And the tissue will start to glow, right? So usually with Graves' disease, you see the entire tissue is gray, right? Whereas a nodule or a hot nodule or TMG and stuff like that, you get different types of presentations. Okay. All right. So that was the general overview of HSN, but now we just have to remember or correlate all these different diseases that you will see throughout the book, right? Even in rheumatology, some in nephro, some in vasculitis, all of that. You have to correlate all of that. Okay. So let's start from the top and just make sure we're covering all these things. Now the if you're serious about the exam, what I need you to do is you need to Google or like at least search for all of these diseases in the book itself, okay? And then go and revise that section from that area, right? So acute hemolytic transfusion reactions. Well, first of all, we're gonna see transfusion reactions in a bit, okay? So we don't need to do that, right? Um, so that's fine, right? But you can see the signs and symptoms are there. The antibody target usually is A, B, O, grouping and stuff like that. Next is autoimmune hemolytic anemia. We're gonna look at that when we do heme and stuff like that. But understand what we just did, right? You have free floating antibodies or bound antibodies that basically destroy the RBCs, right? What do you use Coombs test? What is the pathophysiology? Is usually opsonization. So we understand that. Next is bullous pemphigoid. You see, you have antibodies against hemidesmosomes, right? Hemidesmosomes and the antibodies, once they're bound, they lead to ADCC. So you see that peculiar, the four ways that we discussed how the antibodies actually destroy things, right? So ADCC is there, right? Or it can be antibody-mediated cellular dysfunction, causing receptor dysfunction, basically, right? You see, there's massive amounts of blistering, and because it's hemidesmosomes, usually it's tense, right? It's not gonna pop easily, right? And then you see that there's linear IgG pattern along the basement membrane. So have to correlate stuff like this, right? Might as well go and look at pemphigus vulgaris, which is going to be down here, versus bullous pemphigoid, right? And finish that and come back here, right?
Next comes erythroblastosis. If you study this, it's pretty easy. It's just Rh positivity, negativity. Usually, it's complement mediated, right? And it's RBC antigens use are the Rh antigens, right? Goodpasture syndrome, part of nephritic phenomena, right? How is it happening? Is because of you have antibodies against the type 4 collagen in the base membrane of the lung and the nephrons, right? Leads to ADCC activation. So natural killer cells will sort of just destroy the kidney and the lungs. Okay. Graves' disease. We've seen this antibody-mediated cellular dysfunction. Easy, right? Ascending paralysis. So because of Campylobacter or some other like Zika virus and stuff like that, right? The immune system gets activated. It starts to make antibodies, right? And once you start to make antibodies, you may start to destroy your neurons via the ADCC mechanism, right? And you will see that the immune system and the CSF and all of that will show high amounts of protein. Okay. Next comes ITP. ITP means um, the antibody against the thrombocytes, right? Now, if you have that sort of a thing, you're going to be prone to bleeding and joint bleeding, skin bleeding, bruising, right? TKA, all of that. Okay. Usually it's because of opsonization. So you're marking it for death, and it's going to go into the spleen for phagocytosis, right? Or it's going to go into the liver for phagocytosis. So one of the most common questions is how can you fix the ITP? Take out the spleen, right? If you take out the spleen for an ITP patient, the destruction, you can mark it all you want, but the destruction was taking place in the spleen, right? So you take out the spleen, there's no destruction anymore. It's just going to circulate. Okay. Myasthenia gravis. Myasthenia gravis, what are you making? You're making nicotinic antibodies, right? Acetylcholine receptors, nicotinic type, right? And then usually it's cellular dysfunction. Usually it blocks the acetylcholine action, right? Pemphigus vulgaris, usually it's against the desmosome. The protein is called desmoglein, right? Causes blistering, but this is the thing that will explode whenever you have pressure in it. It'll explode, right? And then you see that pernicious anemia, B12 deficiency, but it's antibodies against parietal cells, right? So it's not giving you any acid to activate that factor, intrinsic factor, right? It needs to be activated by acid. If that is not working, then you get pernicious anemia, usually by ADCC. So damage to parietal cells via natural killer. Rheumatic fever, again, mimicry, molecular mimicry, which you also saw with Guillain-Barré syndrome, but molecular mimicry is leading to this IgG antibody and leading to ADCC destroying your heart, right? Eventually, it will form. Eventually, it will also destroy neurons and stuff, right? We've seen this with something called Sydenham chorea, right? So that's another like a neurophysiological psychological thing. Okay, so that those are like just a bit of the type 2 disorders, right? Make those connections because this will come in handy, right? Once you understand the pathophysiology of all of those, you're going to be great. Okay. Next comes type 3 hypersensitivity. So type 3 is immune complexing. Immune complexes activate complement. Then the complements activate, C3A, C4A, C5A, right? Or they can activate interleukins or other types of, prostaglandins or leukotrienes, etc., right? All of those will lead to activation of cells. And then you see lysosomal degranulation, right? Now, because of that lysosomal degranulation and all of this extra stuff, you see you may start to generate reactive oxygen species and massive amounts of inflammation, right? The thing is, this is hypersensitivity type 3 is the most common pathway for almost all the rheumatic diseases, right? So everything you study in the rheumatology is just based or just, the signs and symptoms are just for SLE, RA, stuff like that, right? So fever, fatigue, weight loss. Skin will show rash. Kidney will show proteinuria, right? Joint will show arthralgia. Mucosa will show ulcers, right? Serosa will show pleuritis or pericarditis. So it's very easy to understand the similarity in symptoms with all of these different presentations because the common pathway of all of them is hypersensitivity type 3. Okay. Usually the treatment from all of these is immunomodulation. Okay. Now, it's best to go to section like hypersensitivity section there, just so we're not missing anything. Yeah. Now, what we're gonna discuss is first this thing, serum sickness. Okay, we have to discuss serum sickness. Um, Now, understand what serum sickness is. Usually because of some sort of medications, right? It can be like an epileptic, or it can be an antibiotic, and or hepatitis B, and or vaccine, right? Usually what these do is they go inside the body, right? They attach to proteins, okay? And the proteins turn into something called haptens, okay? And this is the thing that they're going here, right? Drug plus protein equals haptens, okay? What you start to see is that they will induce plasma cells to make IgGs, right? And once you start making IgGs, you start making the complexes. And because of the complexes, you get the inflammatory reaction, right? Now, the inflammatory reaction leads to, first of all, again, maybe like flu-like symptoms or maybe like allergy-like symptoms, right? But with joint pain and lymphadenopathy, plus you may see proteinuria, right? Because you're causing kidney damage, joint damage, mucosal damage, etc., right? That is called serum sickness. So because of an inciting event, right? It could be, any sort of drug or, hepatitis B or something. You have complement activation and inflammation and tissue damage. That's what we're going for. Okay, and they've given you the drugs and stuff like penicillin and some other drugs. Okay. Now, what is the treatment for this? Usually, it's just antihistamines and corticosteroids. Okay, suppress the immune system. Right. That's the usual reaction. Now, Arthur's reaction is just a local subacute activation. Okay. Usually, it happens because you're giving some intradermal injection, and there's a localized sort of activation of complement. Okay. It's not systemic. Usually, serum sickness is the systemic part, right? And it's dangerous, right? But this is not that systemic. Okay. You may see at the location, you may see fibrinoid necrosis, right? But usually it's not going to be too severe, right? You can manage it, and the treatment is just the same. You have to give them antihistamines, corticosteroids, manage their vitals, etc. Okay. All right. Next comes type 4 hypersensitivity. Usually, all the things that we learned in lecture one about APCs and Th1 activation, Th2, how do CD4 and CD8 work, how do natural killer cells work. This is where we put them in. Okay. Now, the different types and stuff, just so we're not confused, remember contact. Contact dermatitis is usually in the exams as nickel or poison ivy and stuff, which is this compound or Shio, right? Um, so these two compounds will activate the T cells to cause damage. That is contact dermatitis, right? Basically looks like you got burnt in that area, right? You start to get flaccid, bullae and stuff like that, okay? But then the other thing is delayed type of hypersensitivity or chronic hypersensitivity, right? Which basically means you cannot take out the offending agents. They're still sitting there, okay? And because of that, you are constantly in battle with these diseases. For example, TB, leprosy. You see, they are intracellular and they're sitting there. Silicosis, right? They're intracellular and they're sitting there, and you're going to have to mount a response every single time, right? Sarcoidosis, right? You're going to have to, mount a response against, the autoimmune reaction, right? What it usually leads to, type 4 hypersensitivity, because of these Th1 and Th2 cells, usually you're going to see granuloma formation. So mostly, with all of these delayed type of hypersensitivity, you're going to see granuloma because you see, think about it from the immune system's perspective, right? Well, I cannot keep fighting them, so I'm going to contain them, right? The containment protocol is granuloma. Okay. Now, because you have massive amounts of granuloma within, the liver, spleen, lung, mostly seen with sarcoid, right? You're going to start to see organ failure. Or even if this progresses, like the infection progresses or something like that, you're going to start to see some sort of organ failure, right? So that is hypersensitivity type 4. Now, they usually talk about like how do you test for hypersensitivity, patch test, which basically is like, well, I'm going to give them, like the nickel or the poison ivy or something like that in a small patch and see if they actually mount a response a couple of days later or something, right? Or PPD test. PPD testing, if you're not aware of it, just look it up. It's just you inject intra like a subcutaneous injection of TB proteins and you see if they mount a response, right? They've given you a little bit more Candida skin test, right? So all of these are important reactions that you have to cover. Okay. Now the last one basically you need to talk about is DRESS syndrome, right? DRESS syndrome. Now, DRESS syndrome is drug reaction with eosinophilia and systemic symptoms. You see, the general rule which I stated was if you see eosinophilia, you know it's Th2, right? But a lot of people see eosinophilia and they're like, well, that's IgE, which is mediated by type 1, right? That's not the case. You see, Th2 cells are also involved in type 4 hypersensitivity, which means you're going to see eosinophilia here, okay? What is this? Is this like you get massive amounts of eosinophilia and like cellular damage, okay? So if you look up DRESS syndrome, it's usually because of anti-epileptics like phenytoin, valproate, carbamazepine, all of that, right? So DRESS syndrome, yeah. So you may see a rash, right? You may see the rash. Then you start to see either pneumonia, pneumonitis, right? Some other problems. Let me see what else. Yeah, we'll just use this one. Okay. So this is compares. This is a good comparison between DRESS syndrome and SJS, right? Because the two drugs, for example, carbamazepine or phenytoin, can lead to both of these things. So you should be able to distinguish between DRESS syndrome and SJS. Okay. So DRESS syndrome, usually you're gonna see the eosinophilia, right? You can see kidney and liver damage. Usually the skin biopsy will reveal edema, right, with infiltration of lymphocytes, maybe eosinophils, right? But then you look at SJS, you see massive amounts of bullae formation, vesicles and bullae formation, right? Eventually they will explode and they will slough off, and you will see that it this resembles burn victims more than anything, right? Next comes the CBC. CBC is usually lymphopenia, because you're using massive amounts of lymphocytes to target your skin, right? Because of the loss of fluid from these bullaes and stuff, you might see pre-renal type of azotemia, right? Because you're not going to have enough preload to go into the kidneys, right? So you get pre-renal azotemia, right? And then you see skin biopsy, full thickness, complete thickness, epidermis, dermis, everything will be involved with necrosis. Okay, it's a good diagram to keep to understand the difference between DRESS and SJS. Okay, all right. So, all right, now we get into the couple of like unique examples. One unique example is hypersensitivity pneumonitis. Okay, now I've written the entire cascade, but you see, you know, you may not have studied it in depth like this because it's just a small section in respiratory, right? But understand how they're asking it and what exactly is happening, right? Because they can form a lot of correlates with this pneumonitis. Okay, where is it? Where are you seeing this? Farming, animal handlers, textile, right? Cleaning, electronics, chemical workers. Usually, people are just farming, right? But just remember, it can be seen in multitude of occupations. Okay, you inhale something, and the antigens and the self proteins make the haptens, right? It's gonna happen with anything. It's gonna happen with drugs. It's gonna happen with allergens, everything. Why? Because these things like to combine to proteins. That's it. And once they combine to proteins, they basically make foreign antigens. Okay. That will lead to inflammation of the alveoli, right? Because the immune system is recognizing these haptens, and they will start to mount some response. Once you have the inflammation of alveoli and the terminal bronchioles, you may see some granulomas, you may not. You see, fever, chills, cough, chest tightness, right? You may see a rash or a headache, but the thing is, this comes and goes, right? If it does not resolve in 12 days, then it turns into subacute. Usually, this is less than 12 days is the acute part. Subacute is greater than that, 2 weeks. Okay. Now, as you see, it's progressing, right? With subacute, you see fatigue and anorexia. Now it's a problem, right? If a patient is saying, "Well, I cannot get out of bed, or I'm losing weight, I'm not able to breathe properly. I have a chest tightness. I have rash," then you know this it's a problem, right? And then if it's still not resolved and it's chronic, then you see emphysematous lung changes, massive amounts of pulmonary fibrosis, basically restrictive lung disease, okay, or respiratory distress, okay. Now, how do you diagnose this? First thing is you have to do a chest X-ray. Easy, because why would you go straight to CT? Just do an X-ray first and then see what's happening. Okay. The terminologies that they like to use is important. With RESPI, every terminology is important. So the way you start with is subacute, right? Whenever it's subacute, you see some terminology saying micronodular slash reticular opacification, right? So you see, if you this is a very progressive thing, but you see micronodular, right? There's going to be very small white dots. Micronodular, reticular, so this fiber-like, right? Fiber-like opacifications, usually in the middle to lower lung zones. But when it's chronic, you see, it's something called honeycombing, right? Whenever you study pulmonary fibrosis, you should remember that this is a sort of presentation, right? And some parts can undergo atelectasis and loss of lung volume will be seen. So this is the hypersensitivity pneumonitis. Okay. Next comes the things you can measure. For example, IgG, AM, all of that will be high. Okay. Next comes lung biopsy. Lung biopsy will show that you may have like non-caseating granulomas. You may have fibrosis, right? And you can sort of diagnose it out of that. But usually you don't want to do this because first of all they have like loss of lung tissue and they're compromised. Lastly, what you can do is BAL, get whatever cells they have in their terminal bronchioles, suck them out, see, put them in the microscope, see what's going on. Okay. So bronchoalveolar lavage is usually the last, or a couple of things like immunoassay and stuff to diagnose it. But once you understand the physical history and like the work history, you're gonna understand it. Okay. What do you do? First thing is make sure you tell them to stop the offending agent, right? Or wear protective things. Manage it better, right? Next thing you can do corticosteroids, and immunomodulation, which just basically means immunosuppression. Okay, massive amounts of immunosuppression, and then eventually you may need a lung transplant if it's really bad.
All right, so now we're going to get into transfusion reactions. Um, Now, the timeline, of course, important, but the symptoms differ a lot, right? Now, the typical, as you see, the typical timeline, anaphylaxis within seconds to minutes, then you get into less than 1 hour, then you get into less than 6 hours, and then everything else is, at least 2 days to a week, right? So have to remember the demarcations of time, right? Minutes, hours, 6 hours, or like half a day basically, and then 2 days or greater. Okay. Now let's understand each and every transfusion reaction in detail, right? So we're on page 112. As we've seen, allergy or anaphylactic reactions is usually type 1 hypersensitivity. The second sort of mechanism that they want you to remember is a IgA deficient person receiving plasma from an IgA, making person. Okay, because to a deficient person who has never made IgA in his life, receiving IgA from the outside is gonna feel like a foreign, sort of antibody, right? And once they have that antibody in their system, they will basically start to make IgE against the IgA and they will mount a response, right? Very quickly. Okay. Now, as you see, clinical presentation, minutes to hours, and then what you start with is the rash, itching, wheezing, hypotension, and then eventually maybe if it's very serious and not contained, arrest or shock. Okay. What are the cells involved? As you can see here is usually mast cells. Okay. So mast cells are going to be the main one. Then comes acute hemolytic transfusion. Okay, this is the typical thing that we're talking about when we talk about ABO incompatibility, right? ABO incompatibility, you already have preformed antibodies, right? And usually within a few hours, you're going to start, or within that one day, you're going to start to see this, right? So it still goes into that type 2 hypersensitivity, right? Now, the hemoglobin, so the RBCs are going to be destroyed in two places. So it's going to be within the vascular structures, and even in, those who are tagged are going to go to the spleen and the liver, and they're going to be degraded over there, right? So you have intra versus plus extra, right? So you're going to have the bile pigments, bilirubin, and direct and indirect both increasing. Plus, you're going to have hemoglobinuria, right? You're going to have high LDH because now you have both intra versus extravascular, right? So that's where we are. Next comes febrile non-hemolytic transfusion reaction. Now, it's in the name, febrile, right? So you're going to have high amounts of fever, okay? Now, where is the fever coming from? The fever is coming from, the thing is, when you store these blood products, the neutrophils in that blood actually starts to degranulate, okay? And when you actually give it to the person, you're giving those toxins or whatever degranulation that they had, those compounds are going into the bloodstream of that patient, right? So it's going to happen within 1 to 6 hours. It's not too slow, not too quick, right? And it's going to start to cause massive amounts of fever, headache, some chills, and some flushing, right? You can expect that, right? Whenever you give someone transfusion, you can expect that, right? It should go away on its own, okay? Last one is Trali, okay? Trali. Now, there is a difference between TRALI, TRALI, transfusion-related acute lung injury versus TACO. Okay, TACO is um, transfusion-related volume overload. I think the mnemonic is slightly different, but basically volume overload, right? So we're going to differentiate between these two, right? First one is TRALI. Now, understand what TRALI is doing. You have the neutrophils that are in the recipient, right? They've basically become activated. Okay. Now, once they're activated, they, instead of just releasing some of these like cytokines, they're actually going and destroying parts of the lung and alveoli. Okay. They're making them more permeable. Right. So you end up having pulmonary edema and lung injury because you've had a transfusion. Okay. So Trali within 1 minute to 6 hours, you see, febrile and non-hemolytic within 1 hour to 6 hours, right? So this is the two that you've seen before. Now, because you have pulmonary edema and it's like you can understand it's not, the cardiac system is still working, right? So you get non-cardiogenic pulmonary edema. All right. Now, what are you gonna do to sort of remove that water and fix all this? First of all, curb the immune system, right? Give them corticosteroids. Make sure you can give them something like furosemide to drain the lung and stuff like that. And if there's any superimposed infection or anything else, you have to manage those things, right? So usually it's just stopping, immune reaction, okay, using immunosuppressants, which we'll see in by the end of this. All right. So that is Trali, right? Now understand what taco is. So Trali versus taco. Right, so trolley, we just seen trolley and what it does, right? Now we're gonna look at taco. Usually, what this just means is, you've given them a large amount of volume. Okay, you gave them large amount of blood products, right? So it's just volume overload, right? It's chronic. Whenever you have high amounts of blood, right, circulating in the system, you're gonna have the the cardiac system and the respiratory system and the renal system increasing in its overall blood flow, right? So you have to make sure you account for that because some people who have risk factors like chronic kidney disease and congestive heart failure and stuff, they cannot handle that much blood in their system, right? So it might turn into like a pulmonary edema, but it's not like exudative pulmonary edema. It's actually transudative pulmonary edema, right? Because of like positive pressure from the capillaries, right? Now you see the timing is the same. Usually, when you see this is going to be ARDS. Usually, this can turn into an ARDS. But see, the main thing is because this is like inflammation mediated, you will see fever and hypotension. You won't see such a thing over here. Okay. Now this is going to be straight. You're going to have to fix the heart failure or like maybe try and fix the chronic kidney disease and then drain them out, right? But this one, you require immunotherapy, right? The Trali versus Taco, important sort of diagnosis to consider. Okay. All right. Yeah, and last one, yeah, DHTR. Okay, delayed hemolytic transfusion reaction. This is happening because of type 4 hypersensitivity, right? Whenever it says delayed, it's just type 4, right? So now the because of all this foreign antigens and stuff, the T cells and all of that will start to, mount a response against your RBCs, like the donor RBCs and stuff, right? And if there's ever like a bone marrow transplantation or something like that, even that will start to be, degraded, right? All because of like these T cells that are mounting response. So it's slow. It's going to take 1 to 2 weeks, maybe some months. And what you're going to end up seeing is you're going to start to destroy the RBCs within the spleen and the liver, right? They're going to be marked, and then they're going to travel to the spleen and liver and be destroyed. Okay, so you're going to see mild fever, hyperbilirubinemia, and stuff. Um, so they're going to say something about like the person, let's say, having a trauma, some accident, and they receive blood, but then 2 weeks later, or even a month later, they're having massive amounts of jaundice, right? Now, why did that jaundice come about? That is what you're going to explore, right? So extravascular hemolysis, delayed hemolytic transfusion, that's how they go about it. Okay, now that was transfusion. Next comes transplant. Okay, now transplant has its own set of like timeline. Usually when you start to see it, and the first couple of things that you have to see is similar to what you saw with anaphylaxis and stuff. It's hyperacute, usually happens in minutes. But the reason is not just mast cells, right? The reason is that you have like a HLA typing mishap, right? Someone, or some system didn't account for the HLA, being different in the donor versus the recipient. Okay, it wasn't compatible. They have free floating antibodies. They're going to destroy everything, right? HSN type 2. If left in the body, the thing is, if the transplant is still remaining in the body despite having this hyperacute reaction, you're going to start something called systemic inflammatory reaction syndrome, right? SIRS, right? Now, SIRS. So if you want to go deep into this, SIRS criteria. And SIRS versus septic shock has to be understood. Okay, yeah, so let's try this one. All right, so now what we're trying to understand is there's different steps towards septic shock, right? We classify people based on how much organ damage that they have when we're talking about septic shock, right? But when you talk about SIRS, the vitals are the thing that are important. So you have to start to remember these vitals, right? You can have high temperature, high respiratory, high heart rate. WBC is going to show that left shift, which basically means that you have high amounts of WBC, and neutrophils and stuff are very high, right? PCA2 is going to be slightly less because basically what you're doing is, because of some sort of inflammatory reaction going out of control, such as one of them being this thing, right? The hyperacute reaction or this transplant staying in the body, right? It can be some other reaction too, some drug reaction, some sort of autoimmune reaction. Something has triggered massive amounts of inflammation, right? Even something like pancreatitis, right? You classify SIRS if they have all of this, slight fever, and then vitals are skewed, okay? Now, sepsis is basically confirmed when you have the SIRS plus some sort of a given infection, right? This happened because of a microbiology thing, right? Pathology. Now, sepsis, severe sepsis is basically when, one step closer, it means that now you start to have organ damage, which means, for example, neuro, right? How do you gauge someone's neurologic function? GCS scoring, right? How do you gauge someone's kidney functioning? GFR, right? How do you gauge someone's liver? Maybe albumin, right? Albumin and I think, yeah, that I think liver is going to be albumin, PTP and INR, right? PT, and INR, right? Though even that is very acute liver functioning, right? So they take these different like biomarkers and they make sure that these are staying up to date, right? If they're not, then you have a problem. That means you have severe organ damage. Now, then after that, then you get into septic shock. Septic shock means you have the sepsis plus multiple different organs are going to be involved and damaged. Okay.
So the steps towards sepsis important. Okay, right now we're only at SIRS, right? Because you left that transplant organ in, but eventually you may see septic and septic shock criteria coming back over. Okay, so that is the another major thing sort of understood. Now for step two, they like to ask these things. You can take a look at it. It's called the quick SOFA criteria, and there's a complete SOFA criteria. Okay, SOFA just means organ failure assessment. Okay, organ failure assessment. So these are the different things. Like imagine you the Glasgow coma scale is less than 14, right? That means the person is getting stuporous, getting obtunded, and they're not coherent to their surroundings. Respiratory rate is increasing a lot, right? Usually they use MAP, and the MAP is usually around like 80, 90 or something. But systolic blood pressure less than 100, you're concerned, right? So these are very like quick scores to know where the person is at. Okay, so this is called a QSOFA score, quick organ failure assessment. Okay, all right, so that is that. Now we come to acute. So let me just actually go to the transplant page. All right, one more thing when it comes to like transplants and stuff, you have to remember their whenever they talk about transplant, remember what type of micro infection you can see. Okay, a lot of them will show virus transfer. Okay, so for example, if you see here, CMV, EBV, JC virus, all of these are very very commonly tested viruses that are actually seen with transplant, patients. Why? Because you're basically suppressing their immune system, right? So these guys have the opportunistic effect of just going in and causing damage. Okay, so CMV retinitis, EBV, you may start to see the maybe not lymphoma, but at least the lymphadenopathy and stuff, right? JC virus, if it becomes disseminated, the brain stuff, right? BZV, some sort of like suppressed, vesicles coming back now, right? So all of those are, like very common questions when they ask about transplant. Okay, so we did hyperacute, and hyperacute is understood. You see type 2 hypersensitivity. With the hyperacute, the all of these, right? With all of these, most of these, the histology is going to be asked, right? Either described, or they're going to say, here's the pictures, tell us what you see. Okay, whenever you see with hyperacute, the vessels of the graft, right, the tissue that you transplanted, that is going to start to undergo thrombosis. Everything in within that vessel will start to go damaged, right? Eventually, what's going to happen to the organ? Organ is starting to get damaged, ischemia, and then fibrinoid necrosis. Okay, so the tissue itself is going to be damaged, right? So you see in this thing, this is basically the glomerulus, and then I think this is the glomerulus, yeah. And you see multiple like capillaries are being seen here, right? And I think the capillaries are going to be filled with thrombosis and stuff like that. And it's very hypercellular um, thing that you're seeing here, right? I think this actually looks like muscles. I feel like this is muscles and this is the necrosis part. Okay, yeah. So that is hyperacute. This also called like um, yeah, the fibrinoid necrosis. I've seen this in a question too, right? So this can be easily confused with something which I'm going to go into soon. Okay, so just um, I'll bring that point up again. Right now, next comes acute. Acute is happening weeks to months, right? Within weeks to months, where you start to see is cellular and humoral immunity are coming together, right? And with cellular, you see the type 4 hypersensitivity cascade, while humoral, you may have the hyperacute, and it's also associated with C4 deposition and stuff like that. And you see the mishap that you see with acute is usually that you didn't do enough immunosuppression. Okay, so understand what went wrong in order to cause these things, right? Hyperacute is HLA mismatching, but with acute is immunosuppression, right? So when the patient was meant to be transplanted, they are supposed to be immunosuppressed, right? So the immune system can tolerate the foreign antigens, right? If you don't do that, then they're going to mount a response, and this is the usual acute thing that you're going to see, right? Eventually, you see, because hypersensitivity and humoral stuff, you see, you're going to damage the vesicles of the graft. You're going to see lymphocytic infiltrate in the graft, right? and you can prevent it slash reverse it if you give immunosuppressants. Okay, that's the main thing, right? So you see large blue cells, lymphocytes circulating within the system. Okay, all right. So that's acute. Next, next comes chronic, right? Chronic means that it's been a while, months to years. It's been in the system for a while, right? But while it was in that system, the APCs and all the dendritic cells from your tissues are basically invading the, the foreign tissue, right? Eventually, they start to present these peptides to your T cells, and your T cells start rejecting them. They do it slowly, and over time, what you start to see is complete atrophy, right? Parenchymal atrophy and fibrosis. Okay. Now, what is this type? This is the type 2 and type 4. So you have antibodies plus the T cells mobilizing, right? Now the thing is, you see how this also leads to like vessel problems. This leads to vessel problems. This leads to vessel problems, right? All three of them have vessel problems. Okay. But if they ever say which one is going to be the most, geared towards like vessel problems, I think you have to go with chronic, right? See, the thing is, this is, necrosis. This is thrombosis, right? This is arteriosclerosis, which means there is a layer by layer by layer, right? Proliferation of vascular smooth muscles, atrophy, and interstitial fibrosis, right? So whenever they talk about if the vessel wall is obliterated. Okay, whenever they say that, you're going with chronic, right? But whenever they say that, within minutes, or within whatever the transplant was put in, then you saw thrombosis, you're going over this, okay? Now, the reason I say that is because this thing right here, bronchiolitis obliterans, right? In UWorld, one of the question was that they had this lung transplant and something. They're asking you, where is the inflammation located? Okay. Now, with if you don't know anything about anything, you can just go with vascular walls, right? Like terminal arterioles, that's probably the correct answer. Well, for most of them, right? But the thing is with bronchiolitis obliterans, especially because this is like the lung disorder, bronchiolitis, right? You're actually destroying the alveoli itself. Okay, that's just the only special point that I came across, that you might see. But in all of these, right, chronic allograft nephropathy or atherosclerosis, or even this vanishing bile duct syndrome, in all of these, the functioning area is sort of destroyed, right? It's layered upon layered and then eventually destroyed. Okay, so common with you know solid tissues. Okay, the heart, liver, um, kidneys, all of that. Okay, very, very common. Okay, last one, graft versus host disease. I have mentioned it here, but it's towards the bottom, so let me just go there. Yeah. So what is happening with graft versus host disease? The tissue which is rich in blood, usually tissues which are rich in blood, cause graft versus host disease. Okay, usually like liver or bone marrow transplants lead to this. Okay. And what ends up happening is that donor T cells, which are in that organ, mount a response against the host, right? They destroy the host. Now, while they destroy the host, you see, you can start to like, if it's a child, let's say they have leukemia, most of these transplantations for bone marrow, it's a child having like, ALL or something, right? Now, the treatment for ALL is giving them chemotherapy and then bone marrow transplantation, right? Now, within that bone marrow transplant, you start to see that they have something like graft versus host disease, right? So, how is the child going to present? They're going to present with rash, jaundice, maybe bloody diarrhea. The hepatic system and the splenic system are going to be thick, right? And then you see that within the gastro, you may see this, but you may not. Within the intestinal walls, you're going to start to see edema, right? These are not supposed to be this white, okay? They're very, very white. So this is edema within the bowel wall, right? Caused due to circulating probably, inflammatory cytokines causing this bowel wall edematous presentation. Okay. Apart from that, you see within the tissue itself, you're going to start to see apoptotic debris. Basically, the cells of the donor itself are going to go, destruction, and the host itself is going to go destruction. Okay, and usually it's carried out by neutrophils, right? So just to cover everything, you see, T cells proliferate in the immunocompromised host, and the host cells with the foreign antigens lead to organ dysfunction, right? Usually type 4 because T cells are involved, right? So I've given you most of the points here, transplant for leukemia, as you see, and patients, most commonly seen with patients who are immunocompromised. All right, so that was graft versus host disease. Now, within the same breath, what we're going to do is we're going to look at immunosuppression and a couple of other things. So let me see. Yeah. So when I was preparing the notes here, I came across major histocompatibility complex, which is the HLA and stuff, and then the minor histocompatibility complex. Um, just to understand what the difference between the two is, this is going to cause major reactions, right? So usually rapid and strong, quick graft reaction, right? Where this minor one is going to be slower, weaker, and it causes rejection over a period of time, right? This is going to be large glycoproteins, while this is going to be small peptides, okay? And usually this is the thing that leads to graft versus host disease, okay? And this is the one that is involved in like hyperacute and acute type of presentation, okay? If you ever come across that minute detail, just be ready, okay? Now here's some pictures about the different thrombosis events that you can see and all the different cells that may be involved in that. Okay, so you see these are all like this is going to be the kidney, right? This is the glomerulus, but the glomerulus has these like nodules developing because you have thrombosis in those capillaries now. Okay. Last thing is remember what is the meaning of all these allografts, xenografts, autografts, isographs, right? Just Google it. You're gonna be fine. It's not that hard, right? Isographs means I'm taking it from a twin. Autograph means I'm taking it from myself. Xenograph means I'm taking it from an animal. Allograph means I think it's like a sibling, right? So that's what all of this means. So just make sure you review that. Again, a lymphocytic infiltrate within the transplant wall, within the transplanted thing, right? Can be seen with like acute and even like chronic type of thing. Okay. Now we get into sort of discussing immunosuppression. So let's go into immunosuppression. Okay. So the working page is page 118, right? Now, have to remember how these drugs work because they love to ask exactly the compounds and the genes and everything about them. Okay, so you have to start to remember these drugs now. All right. Now, first thing is the TCR receptor. Okay, the TCR receptor is the main thing, right? Once you have the TCR receptor activation, the TCR activates this gene. Okay, this protein basically. It's called NFAT. Okay. Now, NFAT is activated because of this enzyme, calcineurin, right? Now, as you see right away, calcineurin has two inhibitors, okay? One is tacrolimus, another one is cyclosporin. Important to remember both of them, okay? Both of these will inhibit calcineurin, right? Now, if calcineurin is inhibited, you're not going to have the rest of the process happening, right? What is the rest of the process? This NFAT goes into the T cell nucleus and activates this gene right here, NF kappa B. Okay, if NF kappa B is completely transcribed, eventually what you're gonna make a lot of inflammatory products, right? IL-2, IL-4, 5, 6 for Th2, TNF alpha. You're gonna make all of that. Okay, and if you end up making all of that, you're gonna proliferate and have inflammation and stuff going on, right? But in this case, we don't want that, right? We want to modulate the immune system, right? So right now, the two drugs, cyclosporin and tacrolimus, right? Glucocorticoids are naturally, immunosuppressants, which basically go directly into the cell and inhibit these um, targets on their own, right? So glucocorticoids are the third drug, right? Next comes looking at IL-2 receptor, right? IL-2 receptor is the on button for most of these T cells, okay? There is a monoclonal antibody called basiliximab, okay? Basiliximab inhibits IL-2 receptors, which basically doesn't allow this one of these proteins to go in and cause um, like the suppression of these, right? So instead of like actually going to the nucleus, this is basically influencing the protein mTOR, right? So sirolimus, tacrolimus's cousin, sirolimus, right? Sirolimus is important for anyone who has nephrotoxicity with tacrolimus. So we'll see how those two work, right? But the by the way, the name of this TOR, right? TOR is target something rapamycin. Okay, so this mTOR protein was basically discovered because of like rapamycin, the sirolimus, right? All of them are negatively like sort of inhibiting this, so you don't have any proliferation, you don't have um, anything that sustains T cells. Okay. Next comes mycophenolate and azathioprine. The thing is, if you don't give the T cells or even the B cells enough material, raw material, which is nucleotides, right? Then they cannot make their DNA, they cannot make their RNA, right? That's the principle, right? And whenever you see both of these together, you have to sort of remember how they work, right? Because they're seen in biochemistry, they're going to be seen with hemonc everywhere, okay? Azathioprine is 6-mercaptopurine. Basically, goes into this thing, PRPP aminotransferase, which is trying to make nucleotides and DNA for the T cells, right? But this just goes and attaches itself instead of like A and T. You start to have the 6MP within it, right? And as soon as it does that, the DNA polymerase cannot work anymore, right? So it just breaks down, right? So you just put like a roadblock and it just breaks down. So that's how azathioprine works, right? Mycophenolate almost does the same thing. IMP dehydrogenase does not allow the purines to exist. Okay, so you're gonna lose it, and eventually the T cells will undergo death. So that's the drugs that we're talking about. Okay. All right. So just some quick points. Cyclosporin and tacrolimus. Yeah. Compare these two first, right? Compare these two first. Very, very nephrotoxic cyclosporin. What are the questions that they're going to ask, right? The person has chronic kidney disease, or person has some sort of renal functioning disorder, right? And because they have that, you cannot use cyclosporin. That's it, okay? You see tacrolimus, even this has nephrotoxicity. It's similar to cyclosporin, but this has metabolic and neurotoxic effects, similar to this, okay? Gingival hyperplasia. I want you to search for gingival hyperplasia because there are several drugs that lead to gingival hyperplasia. And it's all of them are very, very important. One of them being like phenytoin, right? So how do you differentiate between these two? First, this one has gingival, this one does not. Okay, so cannot be used with people with low renal function. But sirolimus can, not nephrotoxic, right? Um, can lead to hyperlipidemia, can have insulin resistance. So it's not great for type 2 diabetic, but they might just require it, right? Can lead to pancytopenia because you're sort of inhibiting one of the major proliferating um, proteins, right? The signal proteins, which are helping in division, and you're just inhibiting that. So you can inhibit that in the bone marrow, and the bone marrow is lost then. Okay. Next comes basiliximab. We've seen this IL-2 receptor, right? If basiliximab is inhibiting T lymphocytes, remember the thing that inhibits B lymphocytes, rituximab. Okay, they both have X in their name. Basil X, rituximab. Rituximab works with CD20. I wonder if it's here. It's not given here, but you have to remember that. Okay, rituximab is CD20, right? Azathioprine, you see, most of the inflammatory slash rheumatic disorders, azathioprine is a DMARD. Okay, and I'll just show you what DMARDs are. Keep this DMARDs list. DMARDs are meant to suppress the immune system. Okay, suppress the immune system slash suppress inflammation. Okay, so most of the drugs that you're seeing here are very, very high yield. Right, so you see different types of DMARD, right? Methotrexate, hydroxychloroquine, leflunomide, sulfasalazine. I want you to search all of these names within the book. Okay, some of them we have seen, some of them we will, right? For example, rituximab right here. Okay. Some of the genus kinase receptors inhibitors. One of them is definitely important. I can't remember the name, but these TNIP drugs are important, right? So we'll see all of this when we do like RUMAT, okay? But these drugs are very, very high yield, right? So take a second, search all of them up, okay? But for now, we're just focusing on the azathioprine, mycophenolate, etc. Right? So you can take a look at this. You see mycophenolate associated with CMV infection. Okay. Um, Glucocorticoids. I think this all makes sense. Used almost for everything, right? The thing is, couple of questions that they like to ask with glucocorticoids. Because glucocorticoids suppress the proteins that help in lymphocyte to transfer from vascular structures to tissues. Sometimes they say that the vascular pool, right? So there's two pools. Let me just show you. Vascular pool versus tissue pool glucocorticoid. Yeah, if they have a good diagram, it'll make sense easy. I mean, I can just use this, right? Let me see if they have a better one though. Hmm. It's okay. It's not that tough to grasp. We'll just use this whatever this thing is giving. All right. So what is happening whenever you have high amounts of cortisol or someone gets corticosteroids from the external, right? Exogenous means. What happens is you see neutrophils, they start to increase in count, right? Why? Because you're not able to transfer the neutrophils into tissues. Okay. So because they have decreased migration into the tissues, they basically start to increase their count in the blood cell, right? But the thing is, the glucocorticoids actually suppress, we've seen how they suppress it, they suppress the proliferation of lymphocytes. So you may see you have decreased counts of vascular pools of the lymphocytes. But the thing is, the lymphoid tissues, the lymphoid or even like the inflamed areas, might see some sort of increased movement, right? Because if they're there, they're not going to move anywhere else. Okay. While monocytes, eosinophils, basophils, sometimes I've seen, you see, increased in the tissues. Doesn't make much sense, but the thing is, you've suppressed the bone marrow to produce any eosinophils or basophils and stuff. Okay. So questions on this I have seen before, right? They will definitely sort of bring this out from you. Okay. And all the other ones, for example, compare these drugs, right? How are they seen? Where are they seen? All of them, right? So you see, all of them can lead to pancytopenia because they're basically like bone marrow toxic, right? We see this one can lead to hypertension, although this is less nephrotoxic and neurotoxic, right? But that's how they sort of go about it. Another question that they like to ask: if someone has been on long-term glucocorticoid therapy, right? First of all, what are the effects, right? These are the adverse effects. But second of all, how can you manage those patients as a thioprin? Okay, convert them from glucocorticoid users to azathioprine users. Okay, this is for long-term maintenance therapy as a thioprin, right? Well, this is for like relatively long-term therapy until the adverse effects become too much. Okay. So just getting back and just finishing the topic, you see again the how all these things work. Calcineurin, mTOR, you see G1 through S transition is inhibited, proliferation is inhibited. There's new types of immunosuppression. So PI3K pathway, right? The MAP kinase is not allowing transcription of inflammatory genes. Or the JAK-STAT pathway, right? We've seen all of these pathways before, right? If you go into endocrine, right? Go into endocrine and just look at um, how these cell signalings are mentioned. You see, yeah, non-receptor tyrosine. You see JAK-STAT pathway right here, right? So you see all the cytokines, IL-2, 6, IFN. How are they actually working? Through the JAK-STAT pathway. So any JAK inhibitor, right? Any JAK inhibitor, glycine kinase inhibitor, will lead to immunosuppression. right? MEK inhibitors, growth factors, and cytokines. For example, like vascular endothelial growth factor, et cetera, right? Insulin growth factor, fibroblast growth factor. How are they working through this, right? They call T cells, they ask for them for help through by these mechanisms, right? And they've given you a couple more like CDK2 cyclin inhibiting thing that doesn't allow the cell cycle to progress, right? And if you need to revise, what I would say is just go and revise this page. At least look at this page. For example, page 34, right? Here's where is it? Mycophenolate, right? Here's azathioprine, right? Again, it's gonna come back again and again. Methotrexate has several different mechanisms, one here, right? Folate metabolism and purine metabolism, right? Next is, I would say, go into this page right here, which is, yeah, the cell cycle pathway, right? Try and revise this. There's a lot of things that I've used that will come up in this thing, okay? All right, so that's about it for this session. In the next one, we'll sort of go into the immunodeficiencies, group by group immunodeficiencies, and basically finish immuno, and that'll be it. Okay. All right. Take care then.